As a disclosure, I do teach PTP to other surgeons. We're going to be talking about the data behind prone lateral, though. A little bit of an overview. Really, to get an understanding of prone lateral, you have to understand lateral surgery, because really it's just lateral surgery in a prone position. So obviously, lateral surgery is really an anatomical procedure. And we choose fusions based on pathology, accessibility, anatomical considerations. Do you have an access guy, and your training and preference. And obviously, the lateral anatomy is a huge integral component of being able to perform this surgery safely. There's a lot of nerves that go through there that we have to be mindful of. Dr. Uribe described this pretty eloquently, looking at the different zones, and we'll talk about a little bit later that there's a chance that maybe the prone positioning and the way that you position these patients actually makes this more accessible at the L4-5 level, because we know that at the L4-5 level, these nerves creep into zone 3, which makes it a little bit more of a challenge to perform these surgeries safely. Another image just showing these anatomical landmarks. This procedure was first implemented in 2006, where Dr. Pimenta and Bill Taylor kind of described this surgery, and it really kind of checks the boxes of what we want in a fusion procedure, right? We want to maximize fusion, we want to improve sagittal alignment goals, and we want to reduce our revision rates in pseudoarthrosis, bigger grafts. And Mark, maybe we can get it to an ASC setting someday. And so, what are the goals, from a deformity standpoint too? Can we accomplish this? Well, it's the same goal as an MIS standpoint, like a lateral surgery, as an open surgery. We need to have correction of our desired procedures. And there's plenty of literature right now to support the decreased blood loss, decreased hospital stay, and up ad lib walking with lateral surgery over traditional posterior fusions. And then there's some distinct advantages to the lateral approach, right? Larger implant compared to a TLIF or a posterior lateral fusion. And there's a decreased risk of injuries to the CSF leaks and traversing and exiting nerve roots. So anything that involves us going into the epidural space is limited here. And then the advantages, the biomechanics of this allow us to put a cage on the apophyseal ring and then allow us to use indirect decompression, right? And a distinct advantage of the prone procedure is that we don't have to always utilize indirect decompression, because like a lot of you, I don't believe in it for everyone. Kepler's study showed that there was approximately a 35% increase in foraminal height with just a lateral approach alone. But indirect decompression may not be the end-all be-all. There's great indications for it, but there's a lot of times where you have lateral recess stenosis, it's bony stenosis, that just won't improve with an up-down correction and with ligament ataxis. Bill Taylor did a really good job trying to define which of these patients that we can carefully select, but I would argue that with prone lateral, we're able to accomplish all these goals and open decompress if we see it as necessary. And there's some good studies that show that these are pre and post-operative MRIs that we do get good ligament ataxis and improvement of our stenosis from an indirect decompression. And lateral surgery, I think, plays a really, really good role in deformity surgery. And we can do this from a minimally invasive standpoint. And Praveen out at UCSF did a really good job creating an algorithm to determine which one of these patients would be successful in trying to correct their sagittal malalignment with MIS lateral surgery. My buddy Hardeep in Connecticut actually looked at this as well, and he uses a lot of prone positioning to help increase his sagittal alignment for these large deformity patients. And there's some distinct risks in lateral surgery that we have to talk about, right? There's a lot of concern for nerve injuries, and the biggest component of that is effective neuromonitoring. This started with triggered EMGs, which is good for a directional approach to getting our probe down and docking our retractor. But the end-all be-all is actually the saphenous SSEP monitoring. This is going to tell us, once we're docked and doing our procedure, are we able to safely continue with this procedure where we are? Because directional EMGs is just telling us where the directionality of the nerve is. This is going to tell us the health of the nerve root while we're actually operating. So let's get into prone lateral, because we were talking about. It's essentially trans-psoas surgery in the prone position. It allows us to perform everything that we want to do from the spine in a single position surgery in an ergonomical setting that we're used to doing, the way we're used to putting in pedicle screws and the way we're used to decompressing the spine. So it allows for us to directly decompress the spine or incorporate open procedures and deformity surgery while you're utilizing lateral surgery. There's been an increase in the searches for prone lateral surgery. I think most of it was Mark's IP address, if you look at the peak there. But it was first established in 2020 with a cadaveric study, and there's been a lot of iterations of this, and it's gone to more of a procedural workflow with bolsters and the appropriate retractor. So for me, why the switch? Single position surgery was always an interest to me to limit OR time, take the variability out of the flip. We all have great OR staff, but this adds a significant component to our time in the hospital, and I like being in the hospital as little as possible. And it really is a workhorse solution to everything except for your transitional anatomy and L5-S1. And as the data will show, it allows for a significant correction of segmental alignment. I was able to incorporate this in some of my larger deformity surgeries, and it became another tool in my toolbox of treating these patients, right? So it has the same advantages of lateral-based surgery that we've discussed, as well as maybe there's some increased retraction posteriorly of the femoral nerve to allow us to access L4-5 at a safer corridor. And it encourages natural lordosis. We're prone now on a open Jackson table, encouraging that segmental correction. And the bolsters that we utilize allow for some more coronal correction and easier access to L4-5. So Hanjo and the team up at HSS looked at the actual position of the femoral nerve with the prone position with the hip bolsters extended, and they utilized dye essentially, and they did find that there was an increased safe zone to dock your retractor more posteriorly in these patients. And as you can see on the axial cuts of the MRIs, the way that the psoas rotates, it rotates posteriorly and rolls that nerve even more posteriorly, allowing you to have a safer corridor to access. And this is really important at the L4-5 level when we're trying to safely perform this surgery. This was a study by Tyler Smith out west, and they looked at essentially, can we access L4-5 from the prone position? I don't know if it's necessarily better than from a lateral standpoint, but we can do it just as well. We can get access to this level with no problem. And sagittal correction really becomes a big component of this. So this was a study looking at, does sagittal alignment matter? And if we look at it, we look at there's a significant improvement using anterior-based surgeries, ALIF, lateral, compared to TLIF and posterior lateral fusion, improving these PIL mismatch, right? So, why is it important? This has been looked at over and over again, that if we improve this ratio of L4 to S1 lordosis over our global lordosis, our segmental correction, that we're going to reduce the incidence of adjacent segment disease. And this has kind of been published ad nauseum. This was an initial experience by Dr. Pimenta looking at the prone lateral technique. And what's really interesting to look at here is that there was a significant improvement of not only the segmental lordosis, but in the reduction of the PIL mismatch in these patients. There's not going to be, and I wouldn't expect there to be, an improvement in the global alignment because of your reciprocal changes when we're looking at a degenerative patient population, but there was a mean increase of 6.1 degrees of segmental lordosis in these patients. This is a patient of mine that had an outside fusion, went on to collapse at the subadjacent levels, and we did a 3-level PTP procedure on this patient, was able to realign them. Similar patient with 2-level adjacent segment disease. I open decompressed this patient. I thought they had significant lateral recess stenosis. So was able to open decompress them, realign them, get them well within their parameters, all from one position and not having to add that extra OR time. This is a kind of a spot fluoro of that same patient, showing that this was before we had to do any open osteotomies or anything like that. We're getting correction just from the positioning and the cages themselves. Dr. Uribe looked at this. He looked at the improvement of segmental lordosis, and he basically showed the same thing everyone else showed. But what was interesting is he also looked at where you're docking these cages. And I think that's a unique advantage, more so if you're utilizing a dual blade retractor system, which there are a few companies out there that utilize that. And this allows you to dock your retractor wherever you want on the disc space. And I utilize this for different purposes. This is a patient of mine that had kind of a prior fusion of 20 years ago, failed at the subadjacent levels, really had bad up-down stenosis at 3-4 level, and then had a focal kyphosis at the subadjacent level. So I utilized posterior docking for the L3-4 level to get foraminal restoration, but then I wanted to have the anterior for the L2-3 to add lordosis. So you're able to dial in where you dock your cage or dock your retractor to place your cage in these patients, and it really obliviates the need to do an ACR in these patients, in my opinion. This was their post-op images. I also utilized some additional technology, I think, that makes this safer. I utilize a Vision camera system, especially the L4-5 level. This allows for direct visualization of the nerve roots. And ergonomically, I'm 6'4". I do sit down for these, but you can only raise the table so high, so I'm able to look up at almost like an endoscopic screen while I'm performing this surgery. And it involves everyone in the room, I think, which is quite nice. This was a case that I probably wouldn't have been able to safely do without the camera system. This was a big spondy that I ended up putting in the cage first and getting reduction, but if you can see here on the screen, this is actually the root. I was able to pull the dilator out and place it in front of it so I could expand and push the nerve posteriorly. So again, as a kind of a take-home point, I think lateral surgery is an option for a surgeon in their toolbox, and I think adding it from a prone standpoint really just creates it as another tool that you can utilize in degenerative, deformity, whatever you choose to. And I think indirect decompression has a role, and I do utilize it, but I also like being able to open decompress these patients. And I think prone lateral allows for us to do that more successfully. And it's a tried and true technique, so thanks for having me.